Welcome everyone to this edition of the University of Toronto's Gynecologic Pathology Community of Interest. We have, it looks like 37 people on the call right now. We had just about 100 people register, so hopefully more and more people are going to join us as we go on here. And we have people register from Toronto, Greater Toronto area, and different parts of Ontario and different parts of Canada, the US, and actually all over the world. So it's great to have everyone, and welcome. My name's Anjelica Hodgson. I am going to be the moderator today. I'm a gynecologic pathologist at Toronto General Hospital and an assistant professor at the University of Toronto. Just a word about the format. So we're going to begin with a presentation by our guest, who I'm going to introduce momentarily. And then followed by that, there's going to be prepared case presentations from participants in the group. And interspersed between those, our guest expert is also going to show us some cases. As a reminder, you can type questions and comments and other responses in the chat, and we will do our best to monitor those and answer them and acknowledge comments and responses to the best of our ability. And finally, my last reminder is there's going to be a survey that will be posted in the chat at the conclusion of the meeting, and that will also be emailed to you. And if you are interested in getting your continuing professional development credits, you will be required to fill out that survey, and then you will get a certificate. So with that, I'm going to introduce our guest speaker. Just one moment. Whoops. Sorry, wrong one. That's my case. We want this one. Ah, sorry, this one. Okay, there we go. Hopefully that's good. So it's my pleasure to introduce our guest expert today, who is Dr. Jennifer Bennett. And Dr. Bennett is a gynecologic pathologist at the University of Chicago, where she is also an associate professor of pathology. She did her medical training at the University of Florida in Gainesville, followed by residency in anatomic pathology at Penn State Hershey Medical Center. And she completed her training in gynecologic pathology with a fellowship at Massachusetts General Hospital as a Robert E. Scully Fellow. Dr. Bennett is an expert in all things gynecologic pathology, but she has an academic interest in uterine mesenchymal tumors and adnexal neoplasms, and we are lucky to hear from her about those topics today. She is a co-author for the WHO 2020 classification on female genital tumors. She's also the moderator of the always wonderful ISGYP Live Interesting Case Presentation Series. And she is actually the deputy editor-in-chief of the gynecologic pathology section for the very popular website Pathology Outline. So again, we are very lucky to have Dr. Bennett join us. Dr. Bennett, go ahead.
Thank you so much, Anjelica. It's great to be here. Let me just go ahead and share my screen. Okay. Everyone can see that? Okay, so I'm Jenny Bennett. I'm a pathologist at the University of Chicago in the US, how Anjelica said. And I want to thank both Anjelica and Anna for giving me this opportunity to speak at your community meeting. So my didactic portion of the talk will focus on a topic that's near and dear to my heart. It's the STK11 Adenexal tumor that was recently described by myself and others. So I know this is a relatively esoteric entity, but I think it's very important for the general pathologist and GYN pathologist to be aware of its salient morphological features, as it does have a hereditary association that I'll get to momentarily. So I have nothing to disclose. So tumors presumably arising from the mesonephric remnants in the gynecologic tract have been a wide interest to pathologists throughout basically the course of gynecologic pathology. However, in the past, what was called mesonephric was very variable. And the most famous example of such was by Dr. Schiller in 1939, when he described a group of tumors that he called Mesonephroma ovarii and believed that they arose from mesonephric remnants. However, later other investigators found that a subset of the tumors in his paper actually represented yolk sac tumor, whereas the remaining tumors represented clear cell carcinoma. However, in 1973, Dr. Karimajad and Dr. Scully described 9 tumors that arose in the broad ligament fallopian tube area, which they believed to be actually derived from mesonephric remnants, and they named them female adnexal tumor of probable Wolffian origin, or FATWO. So the majority of the tumors in their study arose from the broad ligament. However, a few did arise in the fallopian tube, and as later investigators discovered, a much smaller subset arose in the ovary. So the majority are embedded within the broad ligament. However, rarely you can have tumors that are pedunculated and attached to either the fallopian tube or the broad ligament. So they describe 3 main morphological patterns of these tumors. And often these patterns were mixed without any dominant growth of one of the 3 patterns. So the first pattern is tubular, and it's comprised of solid or hollow tubules of relatively low grade cells without much nuclear atypia or mitotic activity. Another pattern is solid pattern, and it had a lot of times the solid pattern has a spindled appearance that on low power might mimic a sarcoma, but when you look closely, you can see it doesn't have the overt nuclear atypia or mitotic activity that you would expect in a sarcoma. And finally, the last pattern is sieve-like, which consists of these punched out dilated cystic spaces, basically resembling a sieve. Other things that they noted in their series was that a subset of tumors showed these eosinophilic luminal secretions. Although overall the stroma was scant, some tumors did have noticeable hyalinization of the stroma. A few tumors had a glomeruloid appearance, whereas another tumor showed an adenomatoid-like appearance. And the nuclei were low grade, as I mentioned, with inconspicuous nucleoli and rare mitoses, only numbering up to 3 per 10 high power fields. So after the discovery of the FATWO, we had many other discoveries in the course of this tumor's history. So first, the first malignant FATWO was described in 1976, ironically by a Chicago pathologist. And this tumor was actually seen by Dr. Scully in consultation. In 1982, the first series of ovarian FATWOs was described. And finally, in 1999, although there were multiple other studies or small series or case reports using any immunohistochemical stains that were available at that time, the largest series, which is still the largest series to date, used a broad panel of immunohistochemical stains and looked at 25 FATWOs. And this was done by Dr. Tabasoli and colleagues. And finally, the first series of FATWOs that underwent targeted molecular profiling was done in 2018 by Dr. Merkovic and colleagues. And I will go into more in depth into some of these aspects throughout the remainder of my talk. So when Dr. Merkovic published her series, or when it was in press with the International Journal of Gynecologic Pathology, I got the notification and I was like, oh, darn it, that's exactly what I'm working on right now. And so her case was in press. We did present our series of female adnexal tumors of probable Wolffian origin at USCAP back in 2019, I believe. And it was later published in Modern Pathology in 2020. So we looked at 15 fat woes and looked particularly at their morphological, immunohistochemical, and molecular features. So I wanted to point out some similarities between my study and that of Dr. Scully's back in 1973. So the age was similar, both around 40 years of age. Location was similar to being a broad ligament. None of the patients in either series had any recurrences, and all were alive and well at last follow-up, aside from one patient in my series who had died of other causes. Both studies showed the three main growth patterns: tubular, solid, and seed-like, and a subset of tumors showed stromal hyalinization and eosinophilic luminal secretions. However, in my series, there was several differences to note. Two of the patients had extra-adnexal disease at the time of diagnosis. 3 tumors showed this prominent myxoid matrix, whereas 3 additional tumors showed scattered foci of high-grade nuclear atypia, and the mitoses were much more variable in my study, even reaching up to 17 per 10 high-powered fields. So looking at the molecular aspects of these tumors, unfortunately, we were only able to sequence 9 of the 15, as a lot of these blocks were quite old and we were not able to extract good quality DNA. But as you can see from the table on the top, the number of mutations in fat woes is relatively limited. 1 tumor showed 2 mutations in APC, 1 showed a mutation in MBD4, and 3 actually harbored mutations in STK11. One thing to note was we really didn't see the mutations that have been described in endometrioid tumors, high-grade serous carcinomas, most sex-cord stromal tumors, aside from microcystic stromal tumor having an APC, a subset having an APC mutation, and mesenephric carcinomas of the cervix and mesenephric-like carcinomas. So looking at these 3 tumors that harbored STK11 mutations, we can see on the copy number analysis that these were the same 3 tumors that had copy number alterations. None of the other evaluated tumors showed any copy number changes. So then we went back to the morphology, and we had previously reviewed the morphology thoroughly without knowing the molecular alterations in these tumors. And looking at our tables, we found that all 3 of the tumors with STK11 mutations had this very conspicuous myxoid stroma. We also noted that these were the same 3 that had scattered foci of high-grade nuclear atypia. Although the cells aren't overtly pleomorphic, as in something we think like a high-grade carcinoma or sarcoma, they still were enlarged with these prominent nuclei. We also looked at our clinical features, and you can see that 2 of the 3 tumors with STK11 mutations were the patients that presented with extra-adnexal disease. And looking at the mitotic activity, 2 of the 3 with STK11 mutations had higher mitotic activity than one would expect for a typical fat woe. One being 8 per 10 high-powered fields, and the other being the tumor with the 17 mitoses per 10 high-powered fields. So we were definitely perplexed about this. So we went to the literature to see how frequently the myxoid matrix had been described in fat woes, because I was working with doctors Oliva and Young at MGH, and they definitely did not think that this was a classic feature that they had just seen in their large consult series and stuff that they had seen with Dr. Scully in the past. Interestingly, the first report of a malignant fat woe by Doctors Taxi and Batafora, if you look at the microscopic description, we saw that, or you can see that it had, they described a tumor with anastomosing cords of tumor cells surrounded by a loose myxoid stroma. They did have several photomicrographs of this, but once again, this was 1976. So of course, the quality isn't as high standard as what we would expect today. But luckily, Dr. Taxi used to be a pathologist at the University of Chicago, and I met him serendipitously at USCAP one year and told him about this, and he kindly sent me the original slides of the tumor. So this is actually a scanned image of one of the two slides he sent me, no photoshopping, still looks really well preserved nearly 50 years later. But you can see the tumor definitely had this prominent myxoid matrix that looked exactly like the tumors that we had described in the Fatlow series. So now you might ask, what about the tumors from Dr. Merkovic's study where they had sequenced 7 Fatlows? Well, once again, you can see not many mutations in these tumors. However, 2 tumors did harbor STK11 mutations. And one of those patients had Puig-Jaeger syndrome. So definitely we were perplexed, but we still went ahead and reported them in our series on Fatlows. But afterwards, we ended up doing a multi-institutional study where we collected 22 tumors that morphologically looked like the Fatlows with STK11 mutations that we reported, and ended up classifying them as a distinct entity and called that STK11 Adenexal Tumour. So these tumors have a median age of 39 years. And as you can see, that's very similar to what was described in the larger series on Fatlows. But nearly 50% had an association with Puig-Jaeger syndrome, something that is not typical of Fatlows in general. The majority of the tumors presented with nonspecific GYN symptoms, with only a subset being incidental, whereas most Fatlows tend to be incidental and only a small subset present with nonspecific symptoms. Just like Fatlows, the majority were paratubal, broad ligament in particular, the mesosalpinx, and a subset did extend into the ovary or fallopian tube wall. A few arose in the ovary, and we actually had one tumor that was described as multiple small soft tissue deposits throughout the abdominal pelvic soft tissue, and there was no dominant mass that was identified. So 50% of the patients in this series presented with metastatic disease, with omentum and uterine serosa being the most common sites. So here are some histological images of the STK11 Adenexal tumor from our paper. And these tumors definitely have a very broad histological spectrum. But one thing to note was all of them, at least a minor component of all of them showed these intranasomosing cords and trabeculae of cells that percolated throughout a myxoid matrix, as you can see in images A and B. Several of them also showed these punched out cystic spaces, almost looking more cribiform than seed-like and resembling superficially a salivary gland tumor. A few of them also had small microacini, and one of them was so diffuse that it resembled a metanephric adenoma of the kidney. So looking closely at the high power features of these tumors, we'll start in panel B on the upper right. And most of the tumors had these columnar cuboidal cells, whereas a smaller subset had spindle cell growth as seen in figure A. However, the spindle cell growth was normally not dominant. It was only dominant in 2 patients' tumors. Looking at the cytoplasm, it varied from being clear as seen in panel C to eosinophilic seen in panel D. And you can see the nuclei are very similar to what we had said in the Fatlow paper, that they're uniformly atypical. You can see nucleoli conspicuously in the majority of tumor cells. Mitoses are often able to be appreciated. And if you do look closely, you're typically able to see nuclear grooves. However, they're not nearly as conspicuous as one would expect in, say, an adult granulosa cell tumor. So other architectural patterns we saw included solid growth, papillary growth, and macrocystic growth. A subset showed cellular whorls mimicking a meningioma, a squamoid-like appearance, as well as signet ring-like cells. And mitoses were variable, but on the median number of mitoses was 9 per 10 high-powered fields, so definitely more than what one would expect for a fat wall. One tumor was rather interesting, in which it had these strips of bland mucinous epithelium admixed with the tumor. This patient did have Puch-Jaeger syndrome. So we speculated that it is very similar to the mucinous metaplasia these patients can get in the fallopian tube and other locations. And in the lower left, or excuse me, the lower right, we can see some microscopic scatax, and these were seen both in patients with and without Puch-Jaeger syndrome. So we successfully sequenced 21 out of the 22 tumors, including the one that Dr. Taxi had provided from the 2 H&E slides that we received from him. We were actually able to extract good quality DNA from one of the slides and was able to sequence it. So the formalin fixation they did back in 1976 was excellent. And what we found upon our sequencing analysis was that the majority of tumors showed pathogenic or likely pathogenic mutations in STK11. A few did show variants of uncertain clinical significance, and all of those with variants of uncertain clinical significance or those lacking an STK11 pathogenic or likely pathogenic mutation did show a deletion in the STK11 gene. Another thing to note is that very few additional pathogenic mutations were identified, and those that were identified were not recurrent. So how did these patients fare? Well, compared to FATWO, unfortunately not well. 80% of the tumors recurred, and we did have follow-up in 15 out of the 22 patients. And at the end of the study period, 40% were alive with disease and 20% died of disease. And there was no difference based on whether the patient had Puch-Jaeger syndrome as to their prognosis, any morphological features, any immunohistochemical features, or the type of molecular alteration in these tumors. However, the question still remains, what do these tumors originate from? So several theories have been proposed. Mesenchymal is, of course, probably one of the leading theories, since they do arise in the location of mesenchymal remnants. Another proposed theory is sex-cord stromal, since they do express sex-cord stromal markers like inhibin and calretinin. They could also be epithelial, mesothelial, or some other origin that we haven't thought about yet. But nonetheless, I hope you are as excited as me and my little family as to whether to learn more about where these tumors arise from. And I know, given the time constraints, I wasn't able to go into the immunohistochemical profiles or differential diagnosis on FATWOs and STK11 Adenexal tumors. But along with Dr. Esther Leave at MGH, we recently authored a review article on these tumors that's in press in Histopathology. So you can learn a lot more if you're curious as well. It's available in PubMed now. So to end, I wanted to quote a sentence from Dr. Nagali's review article in 1995 on mesenchymal tumors. Sooner or later during his or her academic life, the gynecologic pathologist will almost certainly fall into the trap of writing about tumors of Wolffian origin, as these are such temptingly unusual entities in both female and male urogenital systems, systems. So I think it's safe to say I have definitely fallen into this trap. And I thank you guys for your attention, and I'm happy to take any questions.
So much, Dr. Bennett. How wonderful to have you describe this new entity to us. I don't see any questions just yet from any of the participants, but we have a thank you, great lecture comment. So I certainly don't think I've ever seen one of these, at least that I know of.
You might be surprised.
Yeah, that doesn't mean that it hasn't happened, but what's your sense? Do you think this is an underdiagnosed phenomenon, or is it really actually very rare? What's your sense?
Well, for the review article and for the paper too, we went, the original paper, we went through the literature on all, or excuse me, I went through the literature of all fat woes and any other unusual tumors in the ovaries and adnexal soft tissue, and found that most of the ones that were described as malignant or aggressive, by looking at the provided photomicrographs or the morphological descriptions, it seems like that a large subset were actually STK11 Adenexal tumors or some weird variant of endometrioid carcinoma. So I think they're more common than we think, but they're still definitely rare, just like fat woes in general are rare. But I know Dr. Young is currently going through all of his consult files, and every couple of weeks I get an email from him that said, oh, look, here's a new STK11 tumor, add this to the list. So apparently people were sending it to him throughout his career, but we're only starting to recognize them now. Yeah. But the main thing is to at least even offer that suggestion. I mean, if you don't have access to molecular, it's kind of hard at this point to make the definitive diagnosis, but definitely clinical correlation with the clinician is important, since nearly 50% of these patients have Peutz-Jeghers. So if it's a younger patient and they have either Peutz-Jeghers or symptoms of a that could be suggestive of hereditary syndrome, it would be very important to raise that raise that notion to the clinician.
There's a couple questions from our audience. And this is from Dr. Amani Hassan, and I agree with her. Some of the pictures, I thought, oh, that looks like granulosa. Oh, that looks like intermediate diffs-Sertoli lytic. Oh, that looks like carcinoma, all from the same tumor. So her question is, and Dr. Georgievic has, along the same lines, a more broader question. How do you differentiate? How do you come down on this diagnosis? Let's say if you don't have access to molecular, and even if you do, that's going to take some time, right? So how do you come down on this and differentiate it from other entities that you would be thinking?
Yeah, I think the most important is that most of these arise in the extra-adnexal soft tissue. They don't arise in the ovary. While there are extra ovarian adult granulosa cell tumors and such, they're extremely rare. So I think if you're already starting off as a tumor in the broad ligament that's not a metastasis, you should be thinking about a fat woe. You should be thinking about a STK11 tumor. Immunohistochemically, it can be very hard because I know I didn't go into it, but there's no defining biomarker for fat woes, and same with STK11 tumors is really morphology based. And however, with, I believe, I always get it confused, but I think STK11 tumors are not FOXL2 positive. And I think a subset of fat woes are. You'd have to check, I'd have to check my paper to be sure, but I always get confused with which one has some FOXL2 and which one doesn't. So that's why we're not necessarily convinced that they're sex-cord stromal, since they're not all expressing FOXL2. Same thing with SF1. I think a subset of fat woes can express SF1, but it also depends on the clone you use. And the STK11, I think if we had any, they were very rare SF1. And inhibin and cowretin aren't helpful since they're expressed in both. And then, of course, if you did have access to molecular FOXL2 mutations for adult granulosa cell tumor, and then Dicer1 mutations and a smaller subset with FOXL2 for Sertoli Leydig cell tumor.
There's a question here from Dr. Ju Yoon Yoon, who's thanking you for a great presentation. So he's also saying that he believes that there's a small percentage of PJS patients where there might be somatic mosaicism. And he's asking if that's something that came up in your study or that you're familiar with.
Well, I'm not a molecular pathologist, although I'm learning how to do interpretations for the GYN molecular GYN tumors. But I do not know how you would be looking for mosaicism using just the general targeted next generation sequencing panel, which is what we use. Of course, I'm sure there's probably a way, but I'm just not familiar with that.
Mm-hmm. Another question from me, was this the first presentation that led to the diagnosis of PJS in any of these patients, or were they all known?
I believe they were all known. I mean, some of them we didn't have any follow-up available because they were older cases, so we don't know if perhaps they might have had it and that was just not known by the clinician, but we don't know for sure since we didn't have follow-up.
Yeah. Okay. The other thing that I found interesting was that I believe it was at least one case, but that case with the mucinous component, I mean, it certainly is reminiscent of heterologous mucinous elements in, for example, Sertoli Leydig. So any insight into that, or?
Well, we didn't see any with any other type of heterologous elements. We didn't see any rhabdo or hepatocytic or anything. The thing was, it really did not seem to be replacing the tumor itself. It kind of was just floating throughout it, which I know is very similar to what you see in Sertoli Leydig with heterologous elements. But the morphology of the two tumors is usually so different that I think it's easier to identify. Plus the fact that heterologous elements appear very infrequent in STK11 tumors. And perhaps the only reason that it was seen in this tumor was because they have Peutz-Jeghers syndrome and mucinous metaplasia is quite common.
Mm-hmm. Another question, and people from the audience, please ask your questions to Dr. Bennett if you have any. Do you think that FATWO and STK11 Adenexal Tumour are related, or they just happen to occur in the same spot and sort of look the same, or are they completely different? What's your sense on that?
Well, I personally think that they could be a malignant form of FATWO, because they do look very similar, and that's been shown in the literature how everyone was calling these malignant FATWOs in the past. I know some of my collaborators do not necessarily think they look this, do not necessarily think that they're of mesonephrid derivation, but that's, I mean, everyone's allowed to have their own opinion, but I definitely think that there is some correlation. And I mean, the IHC profiles are so similar too.
Yeah, for sure. Well, that was really wonderful. Thank you so much. I don't see any other questions right now, so perhaps we will move on to the next part, which is we're going to start with the case presentations. So Dr. Lisa Han is going to start us off. And interestingly, Dr. Lisa Han is a former fellow of Dr. Bennett. That's a coincidence, but that's very nice to have that relationship on display here. So Lisa,
yes, hi,
go ahead and start.
Yeah,
hi, Lisa.
Hi, I'm gonna go ahead and share my screen. Can you guys all see the screen?
Yep.
Okay, so thank you so much for having me be part of this presentation, and so happy that Dr. Bennett is here presenting. So my case is a 54-year-old female who presented with a lesion in the vagina. On exam, she had a prolapsing mass in the pelvis. And so
Section
at an
show.
outside hospital, an endometrial biopsy of the polypoid lesion was performed. And it was initially diagnosed as a high-grade endometrial carcinoma with features of clear cell carcinoma and possibly serous carcinoma. At our hospital, she underwent a total hysterectomy and BSO with lymph node excisions and omentectomy. So this is her hysterectomy, this is her cervix. And you can see we have a largely endophytic lesion at the transformation zone of the cervix. It had a maximum depth of invasion of 5 millimeters. So a closer look shows that this was a largely solid and nested tumor with areas of some gland formation and possibly some overlying AIS. When we take a closer look, we see that the nested component had some peripheral palisading of the tumor, and then there's also areas of the solid tumor that showed greater cytologic atypia. The tumor had a infiltrative pushing border, infiltrative and pushing border, and some area had a more micropapillary look to it, which is kind of reminiscent of serous carcinoma, as well as presence of LVI. Immunohistochemical stains showed that the tumor was weakly and focally positive for PAX8, at least the solid component. And then it was largely negative for ER. P16 was strong and diffuse in all of the components. Napsin was negative. And P63 and P40 were both negative. And mucicarmine histochemical stains highlighted variable amounts of intracytoplasmic mucin. So we diagnosed this as an endocervical adenocarcinoma with features of invasive stratified mucin-producing adenocarcinoma. So this entity is likely arising from HPV-infected reserve cells at the transformation zone of the cervix, which retain their pluripotential ability to differentiate into various architectural and cytological patterns. Most of these invasive cases are somewhat associated with its precursor, which is the stratified mucin-producing intraepithelial lesion, SMILE. That entity was originally diagnosed in 2000 as having a hybrid morphology without classic gland formation. It demonstrated mucinous cells arranged in multiple layers, narrowing the lumen of the endocervical crypt and mimicking a squamous lesion like H-cell. And then the invasive component of that was described by Dr. Lastra and other authors about 16 years later, showing stromal invasion, but a similar morphology. So this entity has a wide age range, but most are premenopausal and presenting with vaginal bleeding. There's also a wide range of tumor size with a mean size of 4 centimeters. The WHO classifies these lesions as under the mucinous type of HPV-associated cervical adenocarcinomas. And by morphology, these shows invasive nests of tumor cells with peripheral palisading, variable amounts of intracytoplasmic mucin or clear vacuoles, stratified throughout its entire thickness. There can be a sprinkling of neutrophilic infiltrates, apoptotic bodies, and frequent mitotic figures, as we normally see with HPV-associated cervical adenocarcinomas. As well, it's important to note that there is a mucin-poor variant described, which shows similar morphologic features, but with reduced intracytoplasmic mucin. In the largest case series to date, a good percentage of these were mixed with other components of adenocarcinoma, most commonly with the usual type. And they can coexist with H-cell. Most are showing this destructive infiltrated pattern of Silva C. And what I mainly wanted to highlight was that this tumor shows quite a bit of architectural, or can show quite a bit of architectural and cytologic diversities. So in that same paper with the largest case series, you can see that they can present with this classic peripheral palisading. Some of them can have gland formation. They can even be exophytic and papillary in their growth, as well as more trabecular, as seen in some parts of our case. As well, they can have a micropapillary look, which can conjure up the differential of a serous carcinoma. And then they can also have a single cell infiltrative pattern. For cytologic diversity, they can have eosinophilic cytoplasm, but they can also have a clear cytoplasm, which was probably what was seen initially at the biopsy. And then you can have a histocytoid or even discohesive signet ring-like cells. They can have areas of not so bizarre nuclear atypia admixed with areas with bizarre nuclear atypia, as well as mucin and some hyaline globules, and some areas can look a little more squamoid. The staining patterns are kind of interesting. Like a lot of HPV-associated tumors, these are diffusely positive for P16. About a quarter of them can show a mutational type P53 staining, including null type. I think one study showed up to like 50% of abnormal P53 staining showing a null type staining pattern. PAX8 tend to be less frequently staining compared to the usual type endocervical adenocarcinomas. And while P40 and P63 are often negative, they can be peripherally expressed in the peripheral cells of the tumor nests, regardless of the presence of this palissading. CK7 is positive, as with a lot of endocervical adenocarcinomas. And then HNF1 beta can be positive, but this is often non-specific in that it can stain many subtypes of tumors. Mucicarmin, as in our case, is positive, and MUC6 can be positive too. So in the largest case series, they saw that about a third of these presented with lymph node metastasis, which accounted for its FIGO2 or higher staging at presentation, in contrast to usual type endocervical adenocarcinomas, of which only about 14% presented at this higher stage. They more frequently show this Silva C destructive stromal invasion pattern compared to usual type adenocarcinomas. And retrospective studies, especially some of these earliest ones that I've highlighted in this chart, show that there's a substantial risk for distant metastasis, especially in the lung and pelvic recurrence. So, however, this being an HPV-associated adenocarcinoma, they still tend to have better survival compared to the non-HPV-associated adenocarcinomas. So the main differential, the biggest one, is probably adenosquamous carcinomas, and it's been thought that maybe historically these were often misdiagnosed as such. But keep in mind that these tumors, the adenosquamous carcinomas, should have distinct squamous and glandular components, with the squamous component showing diffuse P63 and P40 expression. If we have a micropapillary looking pattern with diffuse P16 and it happens to have an aberrant P53 expression, you might think of serous carcinoma, but keep in mind that the WHO doesn't recognize the cervical serous carcinomas anymore, and maybe look into the endometrium for tumors arising from there. And also consider HPV testing to help with that differential. And of course, clear cell carcinoma is in the differential. However, although some of them can be P16 diffuse positive, most are not, and napsin can be positive. So yeah, those are the main differentials among others. Thank you so much for this presentation. I'd like to thank my amazing gynae pathology team at Lake Ridge, as well as my mentors in fellowship, which include Dr. Lasser, who was one of the first people to describe this entity, and Dr. Bennett, who's presenting today.
Thank you so much for that, Dr. Han. And it was so comprehensive. You did our job for us. Not much left to discuss, right, Jenny? But again, thank you so much. And yeah, like you said, you know, the initial papers with this presented kind of smaller, you know, groups of these tumors, and then more recently, Dr. Stolnicki and Dr. Park have published 2 papers kind of going over the morphology as well as the kind of clinical pathologic factors with these tumors. And more, once this one in particular, I find, Jenny, I don't know if you agree, but once you've kind of seen it, you're kind of attuned to it. And it's always, I find it always fun when you find these. But like you said, Dr. Han, in my experience too, they often are mixed, so to speak, in that I don't know if I've ever actually even seen a pure invasive stratified mucin-producing carcinoma, and that they often are admixed with gland-forming elements and other types of morphology. Dr. Bennett, what do you think? What's your experience with these?
I haven't seen many, although ironically we had one last week. So, but the ones I have seen have been mixed with another component. The one we had last week was just a leap, so it was very small. But yeah, I'm not really that familiar with them being, or I haven't seen one that's entirely comprised of invasive smile.
Mm-hmm. Yeah. The other thing, there's, as Dr. Hahn said, I think a lot of these were in the past probably called adenosquamous carcinoma, or just poorly differentiated carcinoma, or quote unquote grade 3 adenocarcinoma, something like that. And something that's come up from my own research in this that reviewers often question is why isn't this just poorly differentiated adenocarcinoma? Why do we need to make a specific category and call this its own tumor, basically? And that's a very fair question. But I think, the combined morphology, the combined, evident differences that are coming out in terms of behavior and molecular pathology, et cetera, are supporting that this should be recognized as its own tumor type, as opposed to just being called a poorly differentiated carcinoma. At least that's where I stand, but I have a particular interest in these as well. I don't see anything from the audience. The other thing that I found interesting, I thought Dr. Hahn's case, it had that kind of quote unquote glassy cell look in some of the areas, which is always interesting, whether it means anything or not. But I thought that was very nice, those images that she showed. The other thing, I found the P40 negativity interesting as well. In ones that I've seen, there does tend to be that, as Dr. Hahn said, that kind of peripheral rim of some sort of squamous marker that in my experience that I've seen. But Dr. Hahn's case was really nice and showcased all of the features that we see. So I don't see anything, so I think we will move on. Thanks again, Dr. Hahn, for that. And I think Dr. Bennett is going to do a case for us.
Thank you.
Good job, Lisa.
Thanks.
Okay, so I have to admit my presentation for the slide session is not nearly as inclusive as Dr. Hahn's was, but I will try my best. Okay, so the first case I have is a 36-year-old female who presented with abnormal uterine bleeding. So here's a scan slide of the tumor. You can see up at the surface, we have the endometrium, and the bulk of the tumor is located within the myometrium. However, it does look like it extends focally into the endometrium. And we can kind of see on low power that it has a somewhat nested growth pattern. So zooming in, we can see we have these nests to small nodules of these very epithelioid cells. And I want to point out, you can see these conspicuous vessels adjacent to some of the tumor cell nest. Higher power, you can see that most of them have clear to eosinophilic and granular cytoplasm, nice round nuclei. There are some eosinophilic areas with eosinophilic cytoplasm almost imparting a rhabdoid appearance. And scrolling through, I probably won't find it. Oh, here we go. You can see that we do have some nuclear pseudo-inclusions present as well. But I think you've gotten the gist from this medium power view that mitoses really are not that conspicuous. Something else I wanted to point out, let me zoom back out. This area looks a little different, and when we go to higher power, we can see that there is stromal hyalinization here. So this is not a fat lobe, it's not an STK11 tumor. but we did do a panel of immunohistochemical stains on this, and it was positive for HMB45 strongly in approximately 60% of cells. It was also positive for cathepsin K, desmin, and SMA. It was negative for the most part for MITF and completely negative for melanA, caldesmin, and TFE3. And this is actually from a study I did, so molecular testing was done later on, and this tumor showed a TSC1 mutation. No other mutations were noted. So the final diagnosis is a PCOMA, in particular a PCOMA of uncertain malignant potential. I did hold out that the patient had a history of tuberous sclerosis because I didn't want it to be a dead giveaway from the very beginning. But just to let you know, only about 10% of uterine PCOMAs, the patient has a history of tuberous sclerosis. So most of them are all somatic neoplasms. And this is a table I'm sure you guys have seen either in the literature or in the WHO of different classification systems as to what to call a PCOMA to predict its behavior. So historically, they were classified into benign, uncertain malignant potential, and malignant by Folpe and colleagues in 2005, where they looked at both soft tissue and gynecologic PCOMAs. However, nearly 10 years later, Schoolmeister and others lumped the benign and uncertain malignant potential tumors together and just had, if he showed less than 4 of these atypical clinical pathologic features, it should be lumped in the benign, uncertain malignant potential category, and 4 or more in malignant. And then finally in my series, which has also been later adopted by the WHO, we eliminated the category of benign and made them all uncertain malignant potential because, and we also reduced the number of atypical features to make it malignant to 3 instead of 4. And the reason for eliminating benign was we had one tumor in this group that only had one atypical feature but still recurred. So that's why we couldn't call any of them actually benign, although I have to say if you probably have a little 1 centimeter tumor, no atypia, no mitoses, etc., most likely it's going to behave in a benign fashion. Yeah, so the majority of these tumors harbor TSC1 or TSC2 alterations. What we noted in our recent study was that those that were classified as malignant based on this algorithm, 5 out of 6 of them had concurrent alterations in TP53, RB1, or ATRX. So perhaps the identification of those mutations, which for the most part you can do by immunohistochemical staining, can be used as a helpful adjunct in predicting behavior of these tumors. And I think that's all I have for case 1.
Great, thanks, Dr. Bennett. Yeah, PCOMA, PCOMA. I feel like every single case we're always thinking about PCOMA, and it's always so hard to come down on the diagnosis, and nothing seems to work out the way that you want it to. And such a, I mean, the case you showed, very, very beautiful, but such a morphological spectrum, especially when they become very spindled, it's hard to distinguish from smooth muscle tumors and other things, and very, very challenging. There's a question. It says it's from me. I don't know how it's from me. I didn't type this, but it's under my name. But someone is asking how, and this is a different animal than what you presented, TFE3 associated PCOMAs. How would you distinguish that from what would be quite rare, although not impossible, I suppose, an alveolar soft part sarcoma in the uterus, or I guess elsewhere?
So for the most part, the alveolar soft part sarcomas, their fusion partner with TFE3 is ASPS, although I know, I'm so sorry, I'm blanking on her name from Memorial. And she's helped me with the PCOMA, no, she's helped me with the PCOMA studies. Antonescu, Dr. Antonescu, yeah, sorry, haven't had my lunch yet. I'm an hour behind here. She did describe recently, along with a few of our colleagues, a few alveolar soft part sarcomas that did not have the ASPS mutation, but translocation. But I do not believe that those were in the uterus. You also shouldn't see the crystalloids, the PAS positive crystals in TFE3 translocated PEComa either. And I know the immunohistochemical profile can differ as well too.
Now, what about, your kind of approach, your recent paper that came out has a very nice table that I certainly refer to all the time about when you can diagnostically commit to calling this PEComa. And it seems like that area is becoming smaller and smaller and smaller. You need to fit so many criteria. So, could you talk about maybe your algorithm, I'll call it an algorithm, and how you apply that in your daily practice?
Well, my daily practice doesn't consist of PEComas right and left, unfortunately. I've only seen one in practice. And for that one, it was in a patient who had endometrial serous carcinoma. So it's just an incidental 4-centimeter nodule that everyone thought was a fibroid, but turned out not to be. But the HMB45 was only about 30% in that case. And I think melanate was rare. And I just wasn't able to pull the trigger myself. So even though I've written a lot about these, I still don't feel comfortable necessarily calling them flat out. So for this, I called low-grade epithelioid mesenchymal neoplasm. I think I did say favor PEComas that could send for molecular testing if clinically indicated, which I see Anna just wrote a comment about that. Personally, I don't think you necessarily need to pigeonhole all these epithelioid tumors that express myomelanocytic markers into an actual diagnosis all the time, unless of course they're malignant, they're metastatic at diagnosis, they have those malignant features, but they're not metastatic, or there's concern for tuberous sclerosis. Because I mean, these tumors are just getting more and more complicated as we do molecular testing. And I know a couple months ago, I had a tumor that looked like a leiomyosarcoma. I don't even think it was epithelioid. I can't remember completely. Stained like a leiomyosarc, HMB45 dead negative. So were the other melanocytic markers. And they did molecular since it was metastatic, and it came back with a TSC2 mutation. So I honestly don't know where to go with these. So I think if you're kind of on the fence, it looks benign, I would just, and you either don't have access to molecular, or the clinicians probably aren't going to order it because it looks benign, I would just write the comment like how I did, like low grade, most of these act in a benign fashion. For definitive diagnosis, can send to look for TSC, but otherwise. Yeah,
in my practice so far, I've found my colleagues and I, when we're considering this and we can't come down on something, or if it's for example, not a resection, myomectomy, something like that, we'll often use the spindle epithelioid neoplasm with myomelanocytic diff.
Mhm.
That's something that we fall back on and then describe, like you said, the possibilities. Going back to Dr. Plotkin's question, when do you send for TSC1 and 2 mutation testing?
Well, we've only had one of these tumors since I've been in Chicago, and they said that, and it was that low-grade one that I just described. And if anybody was at USCAP, it was the case example I used for my presentation at the International Society of Gynpath companion meeting. They said that they were going to send it at tumor board, but then they ended up not sending it. They did send the serous carcinoma, but they didn't show, but I think since that's what they were more concerned about, obviously for clinical purposes. However, somehow I was looking at the note later on to see how the patient was doing before I gave my presentation. And the idea for even having a PEComa had completely evaporated. And they were like, there was nothing in the chart anymore about like this unknown mesenchymal tumor. So I think it's definitely something that you need to discuss with your clinicians and tell them the importance about it, both for hereditary associations. And then of course, if it ever becomes metastatic, since TSC mTOR inhibitors are available as targeted therapy. And they actually just completed the first prospective trial of PCOMAs with treated with mTOR inhibitors, and ironically, the GYN PCOMAs had a much greater response than PCOMAs of other sites. So hopeful news for our patients.
Yeah, that's promising. Thanks for letting us know about that trial. I don't see anything else. So thanks for that, Dr. Bennett. We'll move on to the next, and that's Dr. Sharon Nofek-Moses.
Okay, can you see my screen?
Not yet.
Okay, let me just try again. You see it now?
Yes.
Yep.
Okay, let me just put it now on. Yeah, okay. So I would like to present two examples of—
Sharon, sorry, just would you
Yes?
mind switching the display at the top display settings? Top towards the left. Yeah.
Great.
Thank you
Great.
so much. Okay, so I would like to present today two cases from the same entity, and I saw both of them in my personal consultation service, and both were from a surgery that was done in a community hospital settings. So the first case is a 57-year-old. She had a history of premature ovarian failure secondary to treatment of Hodgkin's lymphoma earlier in life. And she underwent bilateral salpingophorectomy and an endometrial biopsy. And this revealed a unilateral ovarian tumor that was solid. It was a small tumor, only 3.6 centimeters. The contralateral ovary had really microscopic benign Brenner tumor. The fallopian tubes were unremarkable, and the endometrium was consistent with benign endometrial polyp and some leiomyomas. And this is a full section, a low power view of the tumor. And even from this blurry image, you can actually figure out that there is some variation in morphology. Here are three different areas. So here on the left, we can see that we have some gland forming areas with a smooth luminal outline, and in other areas we had a bit of mucinous differentiation. Other areas had those anastomosing cords, and overall the nuclear grade looks low, and there is not a significant mitotic activity here. Here is another full section, and you can see that the morphologic heterogeneity is even further seen here, with some areas really showing papillary proliferation with a very minimal tufting. Other areas are more glandular and some irregularities as well. The immunohistochemistry was a bit not ticking every single box. So epithelial membrane antigen was positive, PAX8 was positive, WT1 was diffusely positive, and vimentin was negative. ER was positive throughout the tumor. However, PR was focally positive and was almost negative in those. Overall, the tumor was creatinine negative, but there was an area where creatinine was positive, and you can see it here on a higher power. So to summarize, this tumor is positive for EMA, pankeratin, and cytokeratin 7. It showed diffuse positivity for PAX8, WT1, and ER. The MMRs and P10 were intact. Beta-catenin was membranous, and the PR was kind of positive, except that one area. And I did consider multiple entities in my differential diagnosis, and also the consulting pathologist already provided me with, for example, the calretinin. Hence, I ended up doing so many other immunostains. And my conclusion was that this is a low-grade Mullerian adenocarcinoma. I wasn't sure whether I should favor it to be low-grade serous based on IHC, particularly the expression of WT1, while I felt that only focally it fits the morphology, and morphology fits better with endometrioid adenocarcinoma. So before we go into the diagnosis, I want to show you the next case, which has a lot of similarities. So this patient is also postmenopausal, 60-year-old. She has a history of breast carcinoma and a history of remote vaginal hysterectomy for benign reasons. She underwent bilateral salpingoophorectomy, 4 bilateral ovarian cysts on imaging, and a mildly elevated CA-125. Unilateral ovarian solid mass was found. It was up to 7 centimeters. The surface was smooth. The contralateral ovary was completely benign, and the fallopian tubes were unremarkable. So this is a full, almost a full section from the tumor. And you can see that from this low power, we also have a morphological, I would say, an area that looks more papillary, and other areas that are slightly solid and glandular. And on a high power, we can see again, majority of tumor was glandular with smooth luminal surface. In some areas, the stroma was somewhat more hyalinized. In other areas, we actually saw some secretory changes or pattern. And here's the papillary area. Overall, the nuclear features, when you go on higher power, you can see that the nuclear atypia that we want to see in high-grade serous carcinoma, but it's certainly beyond what we want to see in low-grade serous. So somewhat an intermediate nuclear grade with somewhat open chromatin and a distinct but not prominent nucleolus. In terms of mitosis, it wasn't that much, but it is more than what we want to see in a low-grade serous carcinoma. And let me just think yeah, okay, sure. The tumor was P53 normal, and WT1 was diffusely positive. P10 was lost, and beta-catenin showed the nuclear expression. So to summarize the immunohistochemistry here, again, we have a tumor that is positive for pankeratin and cytokeratin 7, diffusely positive for PAX8, WT1, ER, and PR. The mismatch repair proteins were intact. Beta-catenin was nuclear, P10 was lost. CD10 was positive with luminal accentuation. Again, this was a case that I received with some of the immunohistochemical panel, so I got stuck with it. TTF1 was negative, GATA3, mammoglobin, and gross cystic disease, fibrous protein were negative, and these were important because she had a history of breast cancer. And my diagnosis for both cases was endometrioid adenocarcinoma with aberrant WT1 expression. So I actually wanted to bring up two topics related to these cases. One is previous work that was published by Roman Zilla, who is on the Zoom, and he is one of the U of T residents, and he showed that beta-catenin mutation and aberrant beta-catenin expression in ovarian endometrioid adenocarcinoma correlates actually with better outcome, and this is in contrast to what we know about beta-catenin in endometrial cancers. But really, I want to concentrate on the paper from the McCluggage group that described WT1 positive ovarian endometrioid tumors. And they looked at a series of 23 endometrioid neoplasms, and that were WT1 positive. So WT1 is consistently expressed in low-grade and high-grade serous carcinomas of the ovary, and previously reported negative in ovarian endometrioid adenocarcinoma. However, when I checked immunoquery, the range of WT1 expression quoted there is 15%. Even though we often considered it to be specific for a serous phenotype. In this study by McCluggage, 4 cases were borderline and 19 were carcinomas, and WT1 was positive in all the cases, but in 11 cases it was diffusely positive, and in most of these cases, the expression of WT1 really contributed to misdiagnosis and misclassification of these tumors. In this series, 6 cases had endometriosis, and 7 cases had squamous elements that really helped with the diagnosis of endometrioid. Other clues for nailing the tumor as endometrioid, in addition to endometriosis, would be the presence of endometrioid adenofibroma. And also, you need to think endometrioid if it becomes difficult to classify your case as low-grade or high-grade serous, because the mitosis and the nuclear atypia are more than what you want to see in low-grade serous, but certainly not enough for high-grade. So in this series, most of these cases had normal P53, but in fact 3 cases had abnormal P53. 2 had squamous morioles and were classified as grade 2 endometrioid. And the other one had a subclonal P53 mutation, and this was secondary to a poly mutation. In addition, a presence of psammoma bodies, although by no means specific, is more commonly seen in serous carcinomas. And in terms of the immunohistochemistry, vimentin positivity MMR deficient and P10 loss will be more commonly seen in endometrioid. So other aberrant immunoreactivity is seen in ovarian endometrioid adenocarcinomas. First, they can be negative for ER, PAX8, CA125, and CK7, particularly in metastatic sites. They may express CDX2 and SATB2 up to 20 to 30%. And those have been described in both squamous murals and in glandular elements. And TTF1 is aberrantly expressed in up to 20% of endometrioid adenocarcinoma. So the take-home message is to rely on morphology, presence of endometriosis, adenofibroma, squamous murals, secretory changes, and intermediate nuclear grade and mitosis are a clue. Study immunohistochemistry always in a panel, not in isolation, and consider the aberrant immunophenotypes. That's it.
Thank you very much, Dr. Nofek-Moses. Very nice. 2 cases, lucky enough to get 2 cases from you. Yeah, I mean, endometrioid everywhere is always, can always be a bit tricky. And thanks for showing that article, that recent article with Dr. McCluggage. I found, you know, him and his co-author gave their experience, and the bottom point they came down on, besides, you know, relying on morphology, using a panel, etc., was if it looks endometrioid, don't go down the path of doing stuff, because as Dr. Nofek-Moses said, you're more likely than not going to get into trouble in those scenarios. So if you have convincing evidence of good morphology, there's really, in fact, I believe he comes out and says there's no need to do any extensive workup. Jenny, do you have any comments on aberrant staining in endometrioid cancers?
Well, I was trained with morphology heavy pathologists, so I definitely try not to do that much IHC unless I definitely need it for diagnostic issues. With that being said, I typically don't do WT1 in ovary unless I'm trying to decide, oh, is this a primary tubular ovarian versus a endometrial serous carcinoma, or perhaps sometimes seromucinous versus serous for borderline. But my general rule is if it looks really funny and you're sure it's a carcinoma in the ovary, it's most likely some weird variant of endometrioid.
Yeah, I think that's a phenomenon most people acknowledge, that if it looks weird, and it could be endometrioid, even in the uterus as well, for sure. Yeah, there's a couple people thanking you, Dr. Nofek-Moses, for your really nice and excellent cases in the chat. Okay, I think we'll move on to Dr. Bennett's next case. Thanks again, Dr. Nofek-Moses.
Thank you, guys.
Okay, so my next case is a 44-year-old female with a uterine mass. So this was actually a consult from an outside hospital where they were a lot braver than me and made the diagnosis without any immunohistochemistry. You can see we do have, it's in the uterus, but we do have some uterine soft tissue or adnexal soft tissue. I'm not really sure exactly where this section was taken. And we can see tumor clearly in the vessels. Then if we look at the main tumor mass, we can see it's very cellular. Once again, an epithelioid neoplasm. So maybe you picked up on a theme for my unknown set, or from my slide seminar. This one is a lot more atypical than the last case. You can see we have this mitotic figure that almost kind of looks like a person holding their arms out or something. We also have overt nuclear atypia. Cells are very epithelioid, as I said. And then let me zoom back out. There is some conspicuous tumor cell necrosis here. Well, Yeah, and then there's some other areas where there's definite tumor cell necrosis, as you can see here. So definitely this is in the category of a malignant epithelioid neoplasm. So if this were my case initially, I would definitely be doing the myogenic and melanocytic markers because I have no idea, is this PCOMA versus epithelioid leiomyosarc or something else, but they actually just signed it out as epithelioid leiomyosarc. But and it turns out they were right, but a very brave job by them, because I definitely would have not done that without at least looking for HMB45, given that we, as we talked about in the last case, that there is targeted therapy options. But the tumor was positive for Desmond and ER and negative for SMA, HMB45, melanate, and PR. And then they did end up sending it for molecular. And this one followed the book. It had TP53 and ATRX mutations and loss of P10 and RB1. So it is an epithelioid leiomyosarcoma. So I wanted to bring note to this recent article by Dr. Chapel, who actually was our resident. Actually, I think he was co-residents with Lisa. They were the same year. And this is the largest series of epithelioid leiomyosarcomas that has been published in the literature, because the majority of the studies before, or not the majority, all the studies before were only about 20 to 30 cases and predated IHC and molecular era. So we didn't really know too much about their clinical behavior and how they stain compared to your conventional leiomyosarcomas. We just assumed that they stained very similarly to a conventional spindle cell leiomyoma. So those original studies are what was used to develop the WHO criteria for categorizing an epithelioid smooth muscle tumor as benign, uncertain malignant potential, or malignant. And basically, to call it malignant, you only needed one atypical feature: severe nuclear pleomorphism, or tumor cell necrosis, or I believe it's at least 4 mitoses per 10 high power fields. However, in their study, they discovered that 2 or 3 features of those atypical features were diagnostic of epithelioid leiomyosarcoma. They only had 2 tumors that fulfilled the criteria of only having one of these features, and they called those stump. And they both, I think they had 3, and 2 out of the 3 had a benign clinical course. And so this is their new proposed algorithm. So hopefully it'll be made public, or made as the official diagnostic criteria to for an epithelioid leiomyosarcoma in a future edition of the WHO. I also want to point out, we still really haven't looked at the molecular findings of these tumors that much. This study had molecular that was already performed for clinical purposes in about 10 tumors, and it just showed mutations similar to what you would see in a conventional spindle cell leiomyosarcoma. However, a few years prior, Dr. Chang and colleagues at Memorial did find a subset of epithelioid leiomyosarcomas that harbor PGR, or progestin receptor fusions. And these do look morphologically different than your conventional epithelioid leiomyosarcoma, in which there really isn't that overt pleomorphism. You really get very monotonous cells with uniform nuclear atypia, kind of like how I was describing for STK11 Adenexal Tumour. And they all show positivity for ER and PR, whereas that's only seen in approximately 50% of your conventional leiomyosarcomas. So I think that's all I have for that right now.
Thank you so much for showing us that, and good comparison with the first case. Yeah, I mean, I think in general, we've kind of acknowledged that the threshold for calling something that isn't spindled in the uterus is lower when you have some sort of altered morphology. And is epithelioid LMS something that you put at the top of your list when you get a tumor that's in this family, or?
In an epithelioid or mesenchymal family, or
Yeah.
in the leiomyosarcoma?
In the epithelioid mesenchymal family.
Yeah, I think my main differential usually is between a PCOMA and a smooth muscle tumor. I mean, more times than not, it's going to be a smooth muscle tumor, but since I've seen so many in the research setting, I definitely probably have a lower threshold than many to order melanocytic markers, to order an ALK, to order a STAT6 to make sure it's not a weird SFT. So I kind of have a little panel that I tend to do.
Mm-hmm. What is your panel? Could you let us know what you tend to do? I'm sure everyone is very interested in hearing what your standard approach would be.
If I'm not really thinking that it's a PCOMA, I'll only throw HMB45 on there. If I do think it's a PCOMA, I will throw Melan-A and MITF. We unfortunately don't have cathepsin K at my institution. I do Desmond Cow Desmond. I'm not that big of a fan of SMA. Sometimes I will throw it on either in the initial round or at the end if I'm not getting anything, but I feel like the SMA is so non-specific. If I see any inflammation, I do throw on an ALK, even though most times it's just nothing and you can't get mast cells in a smooth in a leiomyoma and other kinds of inflammatory cells every now and then. After I was involved in the study with a solitary fibrous tumor, I've started adding STAT6 just because that had some very unusual tumor morphologies in it.
I remember that presentation. I was like, oh my gosh, couldn't believe the variability for that, but yeah.
If I'm not completely convinced it's mesenchymal, I will throw on like an EMA to make sure it's not an undifferentiated carcinoma. I don't tend to do CAM or AE13 off that because mesenchymal stuff can stain for pancytic keratins. If there's any rhabdoid type features, I always throw BRG and INI1 on there too. But I think those are, and then so I usually throw ERPR because our clinicians always want to know that the ERPR status. So that I kind of just do without thinking. So
yeah. Great, thank you so much for that and for showing us the new algorithm that Dr. Chapel and Paraharan proposed. Really great and very, very helpful. So I think we're going to move on to the next case, which is going to be presented by Dr. Sakina Thuriai.
Thanks, Anjelica. Can you see my screen?
Yep.
Try quick slideshow. Okay, so hi everyone. So this is a case of a patient who was 19 years old who presented with abdominal discomfort and irregular bleeding. And she had pelvic imaging which showed sort of 8 centimeter solid and multicystic left adnexal mass. Her serum markers were shown there, and nothing really outstanding. And so she went on, because of her age, just to have a left salpingo oophorectomy. So grossly, the ovary measured up to 7 centimeters. It was mostly solid with a tan lobulated appearance, and there were some areas of fibrous tissue. But in addition, a cystic space was noted up to 2 centimeters, which contained strands of hair and tan fibril material. So this is just an image of the gross features, which was not actually taken at the time of grossing, but I went back to the specimen afterwards. And so you can see most of the tumor has this kind of lobulated tan appearance, but there was this area that looked like kind of sebaceous material with hair on one side. So this is just this kind of scanned image of the tumor, and you can appreciate it has this kind of macro and micronodular architecture, but there does seem to be some variation in the architecture, and then there are also these kind of more pinker areas in between these tumor nodules. So going on a higher power, you can see again these kind of variably sized nodules of tumor, and there was some intervening fibrosis. So looking on higher power, the cells were kind of quite large. There were these sort of follicle-like spaces filled with basophilic material, and that's just looking on high power. So again, we can see the tumor cells had these sort of round to oval nuclei, and some of them had nucleoli. That's just kind of, I think, the highest power I've got, just looking at the nuclei of these cells. So they were pretty open chromatin, some of them. But in other areas, the tumor morphology was a bit different. So we had these almost like corded and trabecular areas and nests that seemed to have this sort of peripheral palisading. And just looking at high power in these areas. So this sort of looks similar to the rest of the tumor that I showed previously. And then these kind of trabeculae look morphologically slightly different. And even in these areas, you could see there were some nuclear grooves evident. So the morphology was a bit variable throughout the tumor. And then you can see in other areas, there was this kind of like papillary or pseudopapillary pattern present. And that's just showing on high power those sort of areas. So kind of a variable pattern. And again, you can see these sort of areas where there was sort of almost like rosette type of architecture. Just looking at the high power at that with this sort of peripheral palisading of nuclei. And again, these sort of like rosette or acinar type of formation present. So morphologically, some of the areas were kind of resembling adult granulosa cell areas, whereas other areas look more like juvenile granulosa type areas. And this is just looking at high power at the nuclei in those areas. So we did a reticulin stain, and it was kind of a bit variable. I'll go on high power. So in some areas there was pericellular staining, whereas in these sort of areas there was kind of loss of reticulin staining. So it was kind of a mixed pattern. So just looking at some of the immunostains. So this was the pankeratin, which, you know, as we've said, it can be a bit non-specific. There was some dot-like positivity, but the EMA was negative. And we had some patchy kind of staining for inhibin, as well as a bit less for calretinin. This was CD99, which was kind of diffusely positive across the tumor. And WT1 was basically negative. And then SF1 was also done, which showed strong positivity. I've not shown all the other markers, but there was also kind of synaptophytes and chromogranin were negative, as well as some melanocytic markers, just focal positive. And then, as I showed you grossly, there was that other area with the kind of hair and the kind of sebaceous material, and that was this sort of cystic area here. So you can see it's separate to these nodular areas of tumor. It's kind of adjacent. And then here you can see there was some sort of adnexal and squamous epithelium like we see with teratoma. So it was quite a variable tumor altogether. So basically, I favored that this was juvenile granulosa cell tumor with a mature cystic teratoma as well, and I sent it across for consult opinion. And the preferred diagnosis there was also sex-cord stromal tumor favoring juvenile granulosa, as well as a mature cystic teratoma, with a comment that there were some overlapping features with adult granulosa cell tumor. And of note, there was no Sertoli-Leydig component present. And although unusual, the coexistence of mature teratoma and sex-cord stromal tumor has been reported in the literature. So because there was some kind of doubt between juvenile and adult granulosa, it was sent for molecular testing, but there was no FOXL2 or DICER1 variants were detected. So just a slightly unusual and kind of rare case. So I thought I'd just kind of run through a few points about juvenile granulosa cell tumor. So it's usually in the first 3 decades of life, which is younger than what we'd expect for the adult variant. It's quite uncommon, which is only about 5% of all granulosa cell tumors, which themselves are only about 1% of all ovarian tumors. So it's quite a small proportion of ovarian tumors. Majority are unilateral and are up to about 12 centimeters, and they can be solid, cystic, or a combination of both. And it can have this nodular or diffuse architecture, occasionally pseudopapillary, as in this case. Usually there's not much of stroma, but you can get this sclerosis, and especially when there's nodular growth, as I think we saw in this case. And you can get those kind of follicle-like spaces that often have that basophilic secretion in the center. Usually the nuclei lack grooves, and there's often abundant pale eosinophilic cytoplasm. You can have a brisk mitotic activity, including even atypical forms, and you may have some theca cells. And JGCT can be seen as a minor component of adult granulosa cell or Sertoli cell tumors, so there can be some kind of overlap between these tumors. And usually they're associated with activating alterations in AKT1 or GNAS, and a minority of tumors can be with DICER1 syndrome. And in general, as in this case, if it's confined to the ovary, it's stage 1A, there's an excellent prognosis. But if it is ruptured or, there's extravariant spread, there's increased risk of recurrence. So I think in this particular patient, the plan is that they're going to have close kind of clinical follow-up with CT scans every 3 months. And because of the slightly unusual pathology, they're considering doing molecular profiling of the 3 different kind of morphological areas of the tumor. So that's all I've got. Thank you.
Thanks so much, Sakina. Difficult case. I remember when Marjan got that case from you. Yeah, very challenging. And as you said, I think there has been some reports of these 2 things co-occurring, but to the best of my knowledge, there is no association. And this must be coincidence. What's your sense, Sakina?
Yeah, I think mature cystic teratomas are pretty common. So I think they just kind of happen to coincidentally be present as far as I can tell.
Yeah. Jenny, any comments on that or?
Yeah, I think it's just coincidental.
Yeah.
Or I would favor it to be coincidental.
Yeah, for sure. Yeah, and JGCT, I mean, I must admit I haven't seen many so far. I've seen only a couple, and they're rare, and they're very variable. Jenny, any tips for the audience about how to recognize them or your workup strategy?
I think for the most part, just really looking for the morphological features. So like the cystic, the follicle-like spaces, the larger cells with some moderate to abundant cytoplasm. I feel like for me, the most difficult differential is between that and a small cell carcinoma of hypercalcemic type, because in about 10% of juvenile granulosa cell tumors, you can have breast mitoses and some anaplasia. And for the most part, that hasn't really been shown to be prognostically significant, probably more of a degenerative change. But I mean, missing a diagnosis of small cell carcinoma of hypercalcemic type is a lot worse than missing the diagnosis of juvenile granulosa cell tumor. But luckily we have BRG1 to help us in that differential. Of course, going between adult and juvenile can be challenging. And as Dr. Young always said, just because it occurs in a child doesn't mean it's a juvenile, and just because it occurs in an adult doesn't mean it's an adult. So FOXL2 mutation definitely is our friend. The nuclear grooves you typically don't see in juvenile granulosa cell tumor, or else they're very difficult to find. You also don't see the wide range of morphological patterns that you see in adult granulosa cell tumor. So those are what I tend to look for at least.
Yeah, great. And lots of sampling, right? Always helpful in these things. Great, thank you, Dr. Thuriai and Dr. Bennett. I think we will move on back to Dr. Bennett.
Okay, so next case is a 37-year-old with a uterine mass. So we can see on both of these sections up here, we have endometrium. So this looks like more of a myometrial based mass, similar with down here. We have a little bit of residual endometrium, and it's just an upside down section, probably just to make it fit in the same cassette. Very cellular tumor, very blue. However, when we start looking at higher power, it's kind of diffuse sheets to almost these vague cores of these relatively small brown cells. I'm not sure this particular slide has, oh yeah, it has a pseudo-papillary type appearance in some areas. And when we look more closely at the cells, can see that many of them have this very prominent nucleoli. You also have this abundant eosinophilic rhabdoid globular cytoplasm, and it's relatively almost entirely composed of these rhabdoid appearing cells. And just scrolling through at high power, you can see that it really isn't that mitotically active. Yeah, so that's, I believe the other section is pretty similar. I think there were a few areas that had a little bit more abundant non-eosinophilic cytoplasm, but it was few and far between. So going on to our immunohistochemical panel, I forgot to say that BRG and INI are retained in these, but otherwise it is positive for your keratins, ERPR, WT1, and CD56, negative for myogenic markers, CD10, EMA, and sex cord markers. This was actually a case that was seen in consultation here, I want to say 2012 or so, and it was actually seen at many other institutions in the Midwest too, and everyone gave a different diagnosis. So here it was called, I believe, endometrial stromal sarcoma with rhabdoid differentiation. Other people just were descriptive. It was very variable what people had called but I actually ended up getting the recurrence a few years back. And that's where we ended up doing molecular on it, and it showed an ESR1 and COA2 fusion, which has been recently described in uterus or uterine tumors resembling ovarian sex cord tumor. So this particular tumor, I like to call it a rhabdoid uterus because it shows primarily rhabdoid growth, completely retained BRG and INI1. And the recurrence was very similar for this as well. And I actually collected 2 other cases, and all 3 of the cases showed at least 50% of rhabdoid cells in the tumor. And they all harbored this ESR1 and COA2 fusion. And interestingly, they all had late recurrences. I think the earliest one was 7 years, and one even was 30 years later that it recurred. This particular case ended up being completely negative for sex cord markers, which is unusual, but has been described in uterus. And the rhabdoid features, normally if you see them, they're only focal, they're not exuberant like in this case. So it's definitely something to think of when you get an exuberant rhabdoid differentiation in a tumor. I know Anjelica described one recently that had some rhabdoid features, and it ended up having a GTF2A and COA2 fusion or something very similar to that. And that one recurred a lot like a month later or something too. So so there's been a lot of talk about the molecular fusions of uterus lately. There's ones that have been described with COA 1, 2, or 3 fusions, as well as ones with GREB1 fusions. GREB1 fusions or ESR1 fusions, and COA 1, 2, and 3 can be partners for either of those 2. Some people don't think that GREB1 fused tumors are actually uterus because they have a lot, the morphology is a lot different compared to your classic uteri or uterus. And they might not express sex cord stromal markers. You might not even see any sex cord like morphology. This particular case that I just showed did have the corded growth, but it didn't have the sex cord marker differentiation, but it also did not have a GREB1 fusion either. So definitely very diagnostically challenging tumors when they don't follow the book. But I do have an example of a more classic uterus just for everybody to see here. So the endometrial surface is up here, but it's basically been replaced by the tumor. And when we go on higher power, you can see nice conspicuous cords like you would expect in a uterus. Higher power, some rhabdoid areas, but definitely not greater than 50%. We do have areas that have more clear cytoplasm, since you can get areas like that, than even these rosette type Cal-Exner even looking bodies down here as well. So this particular uterus had an ESR1 and COA3 fusion, which so far none of those with that described fusion have recurred to my knowledge. It's really just been the GREB1s and then the ESR1 and COA2s.
Awesome. Thank you so much. Very, very challenging cases, these, but it's always fun when you get that fusion result and makes the diagnosis for you. But I found, yeah, when you have suggestive morphology and you get that polyphenotypic immunoprofile, in your case, not as great of an immunoprofile as we would have liked, but when you get that epithelial marker, myogenic marker, and sex cord marker all going on at the same time, I find that's quite suggestive. What is your threshold, not just when you suspect UTROSC, but other uterine mesenchymal neoplasms? What is your threshold for ordering fusion testing?
It really depends on the clinical team, because unless I do it on a research basis, a lot of the times the patient's insurance won't cover the sequencing here. Sometimes they only cover specific sequencing panels, like in the States with Foundation One. So it's really variable. I've kind of gotten into my gynoncs that molecular testing, both DNA and RNA, is very important for sarcomas. So they seem very interested in doing that. One of our med-onc actually wants to send all the sarcomas since she's looking for an NTRK sarcoma. So she's like, I want to see one before I retire. So she's into sending all the fusions, or sending for fusion testing. And I've just reiterated to them the importance of doing both DNA and RNA, since of course PCOMAs, unless it's TFE3 translocated, you're not going to detect just based on RNA fusion analysis.
Yeah. Yeah, and your series that your 3-case series, 30 years to recur. Oh dear, we're never safe, and that's scary to think about. Yeah, in our case, just a little side note, we published that case with my co-fellow, Dr. Curto Wajoyo, who's actually on the call and who actually works with Dr. Bennett. So that's interesting. But our case that we followed up. Yeah. Our case that we followed up your series with, as you alluded to, it was bizarre. I think she had metastatic disease at the time, and she had a myomectomy, and then it became clear, okay, this is something bad, and then, oh, she's got disease everywhere. So there was a short lag period, but I think she had metastatic disease, which is unusual as well, as you just said. Usually they're typically, although not always, confined, and then they can come back. But yeah, so ours was interesting, and like you said, ours had rhabdoid as well, so seems to be some sort of morphological marker of aggressive disease, right? So I think we will go to Dr. Michelle Weir next. This will probably be our
Anjelica,
last
there is
case.
one question from
I'm sorry, I didn't see that. Okay, Dr. Nofek Moses, yes. So Dr. Nofek Moses is wondering, what is the proportion of UTROSCs without an identifiable gene fusion?
Well, I think I saw the first author of the Brigham paper, Dr. Goebel, on here.
Yes, that's right. Emily, are you still on?
Hi, yes, I am.
Nice to meet you. I keep reading your paper.
Yeah, very interesting case. You know, when we did this series, the majority of them had those different fusions that Jennifer mentioned, including the GREB1. So I guess we're kind of in the camp that the GREB1s could be UTROSC as well. There was only, if I recall from our paper, we had one that actually was misdiagnosed, but I think most of them had the fusion. So a very small proportion, I mean, there's multiple fusions, right? So a very small proportion don't have the fusion. And as mentioned here, in general practice, we're not testing these for the fusion. It's only in a research setting. So it's hard for me to say exactly how many don't. We usually go on the morphologic features and this broad immunophenotypic profile.
Yeah, so both Emily and Jenny, you make the diagnosis when you have morphology and IHC and everything fits. You don't need to have the fusion for you to make the diagnosis. That's what you're saying?
That's right.
Yeah.
Yes, and actually the second case that I showed you was a case that one of my colleagues here had, and we made it without the fusion. It was actually right when the paper from Dr. Antonescu and Dixon came out describing the fusions, and then my vice chair wanted to know, hey, is this an our tumor? So we kind of did that for fun, but yeah, we typically don't. I mean, but of course they're so rare to begin with, so it's not like we get them every day.
Yeah. Well, thanks so much. Thank you, Dr. Goebel, for providing us with your insight, and thanks, Dr. Bennett. So I think I don't see any more questions. So now we will move on to Dr. Weir. Yeah.
Thank you. Can you hear me okay? Is my volume up enough for everyone?
Yes.
Yep.
Good. Thank you. So I'm going to show you a snapper. Hopefully it'll give you a little bit of a brain break. This is a 71-year-old woman with high-grade endometrial cancer and had a lymph node dissection. So I'm going to show you one slide from the periaortic lymph node. Some very obvious lymph nodes. There were a couple on here. And then there was an interesting finding over in one of the areas that was identified as a possible lymph node by the pathology assistant at the time of gross exam. Going up a little bit higher power, you can see this looks very different from lymph node morphology. It has a lot of very eosinophilic to pale looking cells. And it also has quite a kind of a spindly or vascular meshwork in the background as well. Does not look like the primary tumor. I did some immuno just to confirm what I thought maybe this was. The S100 is beautifully.
But that's good. And yeah, I mean, I guess as you kind of alluded to, Dr. Weir, you know, you don't want to, as with any normal structure, you don't want to confuse it with something that it's not, particularly something malignant. And yeah, I mean, I'm trying to think if I saw that, where would I go? Because I must admit, I don't know if I would have known what that was. But yeah, Jenny, any comments or?
I was actually going down the line of adrenal cell rest first when I saw it.
Yeah, it's a little less organized than adrenal, right? But I suppose it's in the same family. Yeah, I think we'd all land on it's benign, but I'm not quite sure what it was. Dr. Weir seemed to know what it was though when she saw it. But that's great. Thank you so much for that. I don't see any questions or comments, so I think we're going to end with that, and Dr. Plotkin is going to say a couple words.
Yeah, so I would like to really thank Dr. Bennett for joining us, and thank you again for accepting this invitation kindly. And Jennifer is just amazing. I just want to tell everybody how much she helps young physicians from the low to middle income countries, and she really mentors them throughout their career. So that's an amazing job she's doing, and it's so early in her career. Thank you, Jenny, for doing this. That's really amazing.
Thank you for the kind words and the invitation.
Yes, and I think all the cases were just amazing. Thank you, everybody who contributed all the cases. And please remember, you will get evaluation forms. You have to really complete them in order for us to continue with those meetings. And please put your suggestions there. Think about next speakers, your questions, and we always read them, and we take everything very seriously. I also want to thank Anjelica for that wonderful moderation of the session. And we'll see you in about 6 months, everybody. Thank you so much. Bye now.
Bye, everyone.
Bye.